Hi everyone. Can you hear me? Just put in the chat if you can hear me. Or in the Q&A, yeah, great. My name is Ashka. I'm the president of Thursday 15. I apologize for the late start. I've been having some difficulties logging onto the Zoom account tonight for some reason. So I offer my sincere apologies for starting a bit late. Today our session is about obstetrics, and it will be delivered by one of the F1s at the Royal Liverpool Hospital. Her name is Mareed. So she will start the session. I'll make her host and she will share her screen.
Hi everyone, sorry for the delay. We're just having a few technological issues. Just give us 2 seconds. We'll sort it out.
If you've got any questions during the session, feel free to put it in the Q&A and I'll answer as Mareed is going through her session and explanations.
Okay, perfect. Ashka, can you see?
Yes, I can. That's great.
Okay. Hi everyone, as Ashka said, my name is Mareed. I am one of the F1s working at the Royal Liverpool, and I did my BSc in reproductive science, which is pretty much just obstetrics. So it's been a bit of time, but I think we'll be okay. So as far as I'm aware, the format is the same as normal. So it's going to be 14 MCQs today. So I'm not going to read them out to you because you can all read yourselves. So I'll give you basically pretty much a minute per question. If I'm scrolling through them too fast, someone just put it in the chat and we can pause. But I'll leave you to go through them about a minute at a time, and then we'll go through the answers and do some teaching together, if that all sounds okay. So we'll just start. So you've got a minute for each question pretty much, guys, so take your time. Let me know if it's going too fast. Okay, so I'm going to move on to question 2. To whoever asked the question, what time do we think the session will end? I can't imagine it'll take more than an hour. I'm going to aim to finish at 8 o'clock, but between 8 and 8:15, I would imagine. Okay, next question, question number 3. Okay, question number 4. Okay, question number 5. And question number 6. Okay, question number 7. Question number 8. Okay, question number 9. Sorry, losing track of my head. Question number 10. Number. Oh. Right. I'm going to stop sharing for a second, guys, because there should be 4 more questions. So just give me a second. I don't know what's happening with this PowerPoint. 2 secs. Sorry, guys, I don't know what happened there. For some reason, the last 4 slides got cut off, but keep going. So this is question 11. And this is question 12. And question 13. And last one. Okay, everyone, that's the questions done. I'm going to try one more time to fix this. So just give me 2 seconds. Okay, this one looks like it's working. Okay. Did everyone manage to finish, or does anyone want a little bit more time, or is everyone happy? People can just answer in the chat now, because the next bit I would like to be a little bit interactive if possible. Thank you.
Marie, when you go through the answers, I can launch polls for you. So
Okay.
like when you go through each question, so just let me know.
Yeah, is that how people prefer it to be done?
Yeah, that's how we usually do it.
Yeah, that works for me. That's fine. Okay, perfect. Well, it looks like people are ready to go through the answers. So let's just do it. Sorry for the technical issues again, guys. My laptop broke this week, so it's all just been a bit of a nightmare head stir, but we're almost there now. So fine. So question number 1. You had a 29-year-old female come in with a history of passing clear PV fluid. You examined her and found that she had some evidence of fluid in her vaginal canal. Other than a temperature of 38, her obs were completely normal and there were no other concerns. So my question was, which of the following is not recommended in the management of her condition? So I think Ash was open up the poll if everyone can answer it. Obviously I haven't labelled them, but just do A to E as you would. Ashka, how's the poll looking? Has everyone answered? Thank you very much. Okay, so quite widespread. I want to also say from the start that these are quite tricky questions, and I recognise that. They're mostly just questions to get you thinking about it. So don't be too concerned if you haven't got them all right. Obviously, also if you got them all right, there'll be no point us doing the session. So the spread of answers, most people seem to have said D, which is betamethasone. So we'll just run through the options. So options 1 and 2, erythromycin and penicillin, are your antibiotics. Option number 3, nifedipine, is a calcium channel blocker, which in obstetrics is usually used as a tocolytic, so something that stops contractions and delays labour. Betamethasone is a steroid, and magnesium sulfate is used in neuroprotection for fetuses and also used in preeclampsia in obstetrics. So the answer in this case is nifedipine. So this question was asking you for two things. It was asking you what the condition is, and then what do you know about the management? So this patient is 32 plus 5 weeks, and effectively she's come in with rupture of her membranes, as evidenced by the amniotic fluid that's visible in her vaginal canal. I added in the temperature of 38 just to give you a hint at the fact that she might have a bit of an infection on board. What she has, because she's 32 weeks, as well as having rupture of membranes, is it's not just premature rupture of membranes, it's preterm premature rupture of membranes. So premature rupture of membranes is where the membranes break before any uterine activity happens, so before labour. Preterm premature rupture of membranes is where you have rupture of membranes, you have no uterine activity, so no evidence of labour, and also it's before 37 weeks. So the management of PPROM and PROM is slightly different because one is term and one is not term. So we'll quickly run through. So risk factors for preterm premature rupture of membranes is things like smoking, sexually transmitted infections, a personal history, and multiple pregnancy, and that's just because of the stretch applied to the amniotic fluid. The risks of it are chorioamnionitis, that's infection. So once your membranes have gone, you've just effectively got an open source of infection straight through into the uterus. And that's kind of the hinge of this question. Obviously, other risk is prematurity. Part of that will be iatrogenic, and part of it will be, if your membranes have ruptured, it might be that labour is about to start very soon. The diagnosis of it, so you take a history. Often people will, especially if they've had a child already, they might know that the membranes have gone. You can do a clinical examination. You might see evidence of amniotic fluid in the vaginal canal. And you can do effectively kind of a dipstick of the vaginal fluid, looking for insulin-like growth factor binding protein 1 and placental alpha microglobulin 1. Your management is initially expectant, so you might admit them, especially if they're before 28 weeks, you usually would, and then you can treat them as an outpatient, potentially with clinic appointments. What you monitor for is infection and evidence of preterm labour. So for the infection, you give prophylactic antibiotics. So usually first line erythromycin, and you'd give it for, and I think I've written at least, but it's a typo, it's maximum of 10 days or until labour starts, whichever one is earlier. Then second line would be penicillin, antibiotic wise. If you're concerned that labour is going to be in the next sort of 24, 48 hours, you can start thinking about maternal corticosteroids, which is the iron betamethasone. You'd give 2 doses 12 hours apart. And that's obviously to mature the baby's lungs. You can consider magnesium sulfate, especially again if it's preterm and you think delivery might be in the next 24 hours, and that just provides fetal neuroprotection. You don't give tocolytics in preterm premature rupture of membranes because it increases the risk of infection. So you don't want to keep baby in there artificially in preterm premature rupture of membranes. A situation where you would give tocolytics in preterm pregnancy is preterm labour without rupture of membranes. So if the membranes are still intact and the contractions have started, you might consider giving tocolytics to delay the contractions, potentially just for 24, 48 hours, so that you have time to give steroids and time to give magnesium sulfate as neuroprotection before continual management, or you might just try and stop labour entirely. But if the membranes have ruptured, you've got this source of infection, as I said, so you don't want to keep baby in there artificially if labour started. So for that reason, the answer was nifedipine, because you don't give tocolytics in preterm premature rupture of membranes. Does that make sense to everyone? So anyone have any questions about that? So Sinead has asked if, because she's got signs of infection, does it suggest she has chorioamnionitis? Do you want to deliver or wait expectantly? It's kind of on a case-by-case basis. If she's systemically well, you might treat the infection and consider keeping her in there. Depends what other signs of infection she might have. But either way, you're not going to give the nifedipine, which is what the question hinged on. Can I just go through again when you give a tocolytic? Yes. So you might give a tocolytic if you have preterm labour. So I'll go over a little bit again. So premature rupture of membranes is when the membranes have broken, but there is no uterine activity to suggest labour. So membranes are broken, but you're not in labour. Preterm labour is slightly different. You can still have your membranes intact, but you might have started signs of labour. So you might have started contractions, your cervix might have started dilating. Because remember, it's not like in the movies, the first sign you get of labour isn't your membranes rupturing in general. In general, that's quite late to go. So if someone has preterm labour, but their membranes are still intact, you might consider giving tocolytics. And the idea of that would be to either stop labour or to delay labour for long enough to give corticosteroids and to give neural protection to the fetus. If you have preterm rupture of membranes, but you haven't got any uterine activity, so you've not got any signs of labour, you're not going to give tocolytics, you don't want to artificially delay labour because you've got this open route of infection into the womb. Does that make sense? It's a bit confusing. They're slightly different, preterm labour and preterm rupture of membranes. They're not the same thing. Does anyone have any questions about that? Sorry, I know it's a bit complicated. There's a few complex things in obstetrics that I'm going to try and clarify things between today. Someone's asked what the main indication for magnesium sulfate is. That provides neuroprotection to fetuses who are in preterm babies. You don't always give it, but it's something to consider you can give. What's the difference in management from pre-prom and prom? Well, so prom, they're at 37 weeks, so you're much more likely to just deliver them. Whereas preterm, premature, they're before 37 weeks, so depending on the gestational age, you might try and keep them in there a little bit longer. That's really the difference in management. Okay, is that all the questions for this question? Is everyone happy to move on? If anyone says yes, I'm just going to move on. Thank you. Okay, so question 2. You have a 26-year-old lady who's come in, she's fully term, she's in labour, in this active second stage. She's delivered the head of the fetus. Fetal head is delivered and it's restituted, so it's turned, but the shoulders haven't delivered. You've tried normal traction, shoulders still haven't delivered. So again, there's 2 questions here. What is the condition and what's the management of it? So Ashka, can we just do a poll again, please? Thank you. Maybe give everyone like 10 to 15 seconds then, Lisa, if there's enough feedback. Okay, so most people have said A, which is absolutely right, well done. So The condition here is shoulder dystocia, which hopefully most of you have recognised. The options here were wood screw manoeuvre, which was the correct answer, and we'll go through a little bit more about shoulder dystocia in a minute. The other options were, so Dix, Hallpike, Pinard's and Epley's are all Otto, like ENT tests basically for manoeuvres for BPPV, and the Heimlich manoeuvre is obviously for people who are choking the abdominal thrusts. So the answer was wood screw. So shoulder dystocia, really important to know about. It's an obstetric emergency, and what happens in shoulder dystocia is, as the baby's coming through the pelvic inlet in the vaginal canal, the anterior fetal shoulder, so the one on the top, is impacted on the maternal pubic symphysis. So the head's gone past, the shoulder can't get past, and it just butts it like this. So you'll have delivery of the head, and then you won't be able to get that shoulder out. Keeping the baby in risks, at this stage, risks fetal hypoxia. That's why it's an emergency. And the time in delay for delivery is proportional to the level of hypoxic injury to the fetus. So the faster you get the baby out, the better. Risk factors for shoulder dystocia. So what I like about obstetrics is a lot of it's common sense. So risk factors for a baby getting stuck are a personal history of babies getting stuck. So it suggests your anatomy maybe isn't quite perfect for delivering babies. Macrodomia, so a big baby, more likely to get stuck. Induction, prolonged labour, so labours in general has been quite slow. Use of oxytocin, high maternal BMI. Risks of shoulder dystocia. So in obstetrics, we usually split it up to risk to the mother, risk to the baby. So risk to the mother, it's more likely to be a traumatic delivery. You're more likely to have tears. You might need an episiotomy, therefore are more likely to bleed. Risk to the baby, the shoulder might get broken, so you might have a fracture of the clavicle of the shoulder. That might be iatrogenic, we might do that as part of the management, or it might just happen due to trauma. You can have injury to the brachial plexus, again, can be due to getting stuck, but it's more often due to doctors pulling. Hypoxic brain injury, as I already said. Diagnosis is just clinical, as I said, in this emergency, so you need to be able to recognise it. You might have already had a bit of difficulty delivering the head, and especially the chin of the fetus. Head might have fully delivered, but it doesn't restitute quite right, so it doesn't quite turn on the side the way it should. Or you might get something called turtleneck sign, which is where the head delivers through, so the head's delivered fully, but then it starts to retract and pull back. So you can't see the neck of the fetus. That's the turtleneck sign. The head's come out fully and then it starts to pull back. Management of shoulder dystocia. First thing, as the same as you do in any emergency, which you'll all learn, especially in F1, is call for help. Then you're going to ask mum to stop pushing. It's not working. You need to try something else. Make sure you only apply routine axial tractions. That's keeping the baby's head in line with the baby's spine. You don't want to start pulling up, pulling down, because that's when you start to risk damage to the shoulder. You can consider an episiotomy at this point. Now, it's important to remember that the episiotomy won't do anything to fix the shoulder dystocia. So the blockage is further up. It's where that shoulder's hitting that bone. So doing an episiotomy will give you better access if you're needing to insert your hands into the vagina, but it won't do anything to help the shoulder dystocia. It also reduces the risk of the mum tearing in a way that's less optimal than the cut and the degree that you make. First thing you do, and this works for 90% of shoulder dystocias, is something called McRoberts manoeuvre. So what you do, mum's lying on her back, you pull the knees right into the chest as far as you can go. And the idea is that opens up the space in the sacrum and allows baby to deliver. At the same time, you can apply a bit of suprapubic pressure, and what you're effectively trying to do is knock that shoulder out from underneath the pubic symphysis. So you can apply pulsing pressure to knock it out. You've got to be careful to make sure you're applying suprapubic pressure and not fundal pressure. So fundal pressure is what we use in postpartum hemorrhage, and that's pressing on the uterus. You don't want to do that in shoulder dystocia because you'll risk uterine rupture with the baby still in there. So suprapubic pressure, knees into chest is the first move. If that doesn't work, there are a few more manoeuvres you can try. So you can try delivery of the posterior arm, where you just reach in, grab that posterior arm, pull it out, and that aims to free baby. You can try Wood's corkscrew manoeuvre, where you put effectively pressure on the front of one shoulder and on the back of the other, and you try and twist the baby's shoulders into a better plane for delivery just to free them up. Rubin 2's manoeuvre is very similar. You just put some pressure on the anterior aspect of the posterior shoulder and try and push the shoulders back into a better angle to deliver. You can try all those with mum still on her back. If that's not working, pop her onto all fours, try them all again. And then when it's getting a bit drastic and you still haven't got baby out, things you might consider, I mean, you would not consider, but an obstetric consultant would consider, are clidotomy, so that's breaking the baby's clavicle to make it easier to deliver. Symphysiotomy, so that's breaking the mum's pubic symphysis or cutting the mum's pubic symphysis. And then Zavanelli manoeuvres, which are effectively reversing the stages of labour, so pushing baby back inside to the pelvis, and then you would go to theatre and perform a C-section to get baby out. That's pretty much it for shoulder dystocia. Does anyone have any questions on it? Anyone? Or is everyone happy to move on?
There's nothing in the chat or in the Q&A.
Perfect. Okay, fine. I'm just going to assume everyone's good to move on then. So question number 3. You had a 34-year-old come in at 36 weeks, her baby's breech. The proposed management was an ECV, which is an external cephalic version. And the question is, why can you not do that in this patient? So everyone can answer the poll. And Ash, could you just share it when enough people have answered? Okay, so almost everyone answered answer C. It's absolutely correct. Well done, everyone. So I'll go through this relatively fast then. Breech presentation. So all pregnancies start as breech presentations. So baby is head up towards the top in the uterus. Later on in pregnancy, baby flips into a nice position for delivery. Some babies don't flip, some babies flip halfway. If a baby doesn't flip, they're breech. Often babies might be breech at 32 weeks in that scan, but actually they'll still flip a bit later and be vertex presentation by 36, 37 weeks. If they're not flipped and they're in breech presentation, there's a few different managements you can do. So one of them is an ECV, which is an external cephalic version. I don't know if people have seen it, but effectively what you do is you give mum some analgesia and sometimes some muscle relaxant and some gas and air, and you push on the outside of the tummy and try and physically push the baby around. Sometimes it works, sometimes it doesn't. It's about 50%, and some of the time baby will still flip back round. The risks are fetal distress, which might mean you have to go for an emergency C-section, and placental abruption just because of the pressure you're putting on, again, which would mean you have to go for an emergency C-section. Another option is an elective C-section. If you know baby's breech, you can just decide to have a C-section. That has some implications on future pregnancy and future deliveries. It has a small reduction in perinatal mortality. The other option is a vaginal breech delivery. We don't do them super commonly in this country, and often I think that's just because they're not seen super commonly, they're not taught super commonly. Other countries do them much more often. If they're successful, they have the fewest complications, but 40% of them need emergency C-section, usually due to fetal distress. You cannot do a vaginal breech delivery if it's a footling breech. So there's 3 types of breech: frank, complete, and incomplete, which is a footling presentation. So in a frank breech baby, they're effectively folded up in half, legs tucked right up next to their head. In a complete, they're kind of in the fetal position with their legs crossed, but they're still tucked up. And in footling, one of the legs at least is extended, so kind of lying flat. There are a few risk factors for breech presentation. So anything that changes the shape of your uterus, so uterine malformation, fibroids, impacts the ability of the baby to turn. So do abnormalities with the fetus themselves. Changes in the level of fluid might impact the ability of the baby to turn. And then prematurity it makes sense, because if babies are breached throughout pregnancy and only turn late on, if you're delivering a baby early in pregnancy, they're less likely to have had the time to turn yet. That's pretty much everything for breach. Does anyone have any questions on that? Nope. At what gestation is ECB contraindicated? It's not really contraindicated at a gestation. I saw one at 41 weeks. They tend to do them at 36 and 37, depending on if you are nulliparous or multiparous. So they're doing them a week early if you're nulliparous, I think it is, and a week later if they're multiparous. But when I was in obstetrics, they would attempt them up to 41 weeks. It's not really contraindicated at a certain point in terms of gestational age. There's no point doing them really before 36 weeks, because they might still turn themselves, or they're at a higher risk of turning back. Obviously, the bigger the baby is, the harder it is to turn them, and the less likely it is to work. Also, the later on in pregnancy, yeah, sorry, I don't know where I was going with that, but yeah, that's basically the point. So it's not really contraindicated at a later gestational age, but they might feel there's less point the later on you go. Okay, I think everyone else is happy to move on, so let's keep going. Question number 4. So this is a lady, 35-year-old, who's in labour. She's expecting twins. She had an uncomplicated pregnancy, and she has gone into labour spontaneously at 38 weeks. She's got a history of factor V Leiden. Which of those things about her is likely to increase her risk of postpartum hemorrhage? So if everyone can answer on the poll. Thanks, Ashka. And if you just release it when enough people have answered, that would be great. Amazing. So it's a split between C and D. The factor V Leiden I kind of put in there to throw people a little bit, because I thought it was too easy, so I understand why a lot of people have gone for that. Factor V Leiden mutation increases your risk of clotting, not your risk of bleeding. So it could slightly increase your risk, because you could have a clot that bleeds, but actually overall it's less likely to reduce your risk of bleeds. However, twin pregnancy very commonly will increase your risk of postpartum hemorrhage, and we'll go through why. So postpartum hemorrhage, cause-wise, we consider the 4 T's. So trauma, and that can be trauma from tears, or it can be trauma that we create through things like episiotomies. Tissues, that's retained tissue, so things like retained placenta, or retained parts of placenta. Tone is the biggest one, the most common, and that's just the uterus not contracting down sufficiently after labour, and there's lots of things that can cause that. Some of the other ones can cause it. For example, retained tissue will cause a problem with tone, because the uterus won't be able to clamp down. And thrombin is the other one, so conditions like preeclampsia increase your risk of bleeding. I've written risk factors being Anthony, obviously that's meant to be Anthony, not Anthony, sorry about that. Multiple pregnancies, so you've stretched the womb more, so it's less easy to clamp down. Macrosomia, again, you stretch the womb more. Oxytocin, retained placenta, as I've already said. Episiotomy, for the same reason, you're making a cut, it's more likely to bleed. Placenta, accreta, increta, percreta, anything where you're burying into the wall of the womb is more likely to have difficulties coming away, likely to bleed when you try and remove it. Preeclampsia, as I said, the thrombin, and then C-section, because you're cutting the womb, again, likely to bleed. And multiparity is kind of for a similar reason to for pregnancy. You've stretched the womb multiple times, it's less contractile. We classify it as primary and secondary. So that's primary is within 24 hours, secondary is between 24 hours and 12 weeks after labour. You have minor and major. So minor is between 500 mils and 1 litre, and major is anything over a litre. So your management, the first thing you do is try and reduce the risk. So everyone is offered IM oxytocin in the 3rd stage of labour, usually as you deliver the shoulders or as the head is delivered. You'll given IM injection into the thigh of oxytocin to help the uterus start to contract. You can give tranexamic acid if you know they've got risk factors with postpartum hemorrhage, and that's quite commonly given now in labour. As with all emergencies, A to E approach. For this particular one, obviously you'll put out a major hemorrhage protocol, major obstetric hemorrhage protocol. First thing you can do, you can try and remove any retained products if you know there's placenta in there. You can massage the uterus, and that's a bimanual massage. So you'll put one hand inside the vagina, one hand onto the fundus and put some pressure in. You can give medication like syntocinon, ergometrin, carbobros, things that clamp that uterus down. You can try physical interventions, things like a balloon tamponade, so that's inserting a balloon through the vagina, inflating it, and effectively that just puts pressure onto the uterus. And you can try surgical intervention, so artery ligations and embolizations. At the absolute extreme, you can do a hysterectomy. If you take the uterus out, the uterus cannot bleed anymore. That's it for postpartum hemorrhage. Does anyone have any questions on that? Why is oxytocin a risk factor and management? Yeah, good question. So oxytocin, if you're using oxytocin throughout labour and you have, or to augment labour, and you have been the one artificially contracting the uterus, if you stop using that when baby's delivered, the uterus might not contract effectually anymore because it hasn't actually really been doing it for itself the whole way through. So what you can then give is some more oxytocin, some more syntocinon to help it clamp down. Does that make sense? So it's not the oxytocin causing the problem, it's the fact that you've had to use oxytocin to get the contractions going. That's the risk factor. Does that make sense? Perfect. Anyone else have any questions? Can I repeat why it's not factor 5? Yeah, so factor 5 Leiden mutation is a thrombophilia, not a haemophilia. So a thrombophilia increases your risk of clotting, whereas a haemophilia increases your risk of bleeding. So factor 5 Leiden won't increase her risk of postpartum hemorrhage particularly. It might slightly increase her risk of getting a clot, which can then bleed, but no. Yeah, that's fine. I'm happy to repeat myself. So oxytocin is a risk factor because if you've had to use oxytocin to augment labour or to artificially stimulate labour effectively, the oxytocin is the thing that has been causing the uterus to contract or encouraging the uterus to contract or increasing the frequency of uterine contractions. So if you've used that throughout labour and that's how labour has gone, you stop using it at the end because baby's delivered and placenta's been delivered, then the uterus hasn't actually been really cramping for itself throughout labour, and you've not got anything stimulating anymore, so it might not clamp down the way that it should. So you might need to give some more to encourage that contraction. Does that make sense? Whoever asked that question? David. Yeah, perfect. Okay. Any other questions? No. Right, keep going. Sorry, this is taking a bit longer than I thought, guys. I didn't. It might not finish. I mean, it hasn't finished. Question number 5 is about chickenpox in pregnancy. So this lady has never been exposed to chickenpox, has never had chickenpox, but has now, at 16 weeks pregnant, been exposed. So the question is, what is the management option that she should be offered? She should be offered antivirals, antibiotics, a vaccination, immunoglobulins, or should we just watch and wait? So Ashka, if you can put the poll up again, please. and then just release it whenever you want, when enough people have answered it. That would be fantastic. Yeah, absolutely right. Well done. Pretty much everyone got that as well. So I'll just fly through the answer. So the answer was varicella zoster immunoglobulin. So chickenpox. Most people don't consider it to be a big deal because lots of us get it when we're babies, but in pregnancy it's a very big deal. Obviously, pregnancy makes you a little bit immunocompromised. So risks to the mother are especially things like pneumonia, hepatitis, and encephalitis. Risk to the fetus can cause blindness. It's one of the most common things that it causes. Can cause seizures in a fetus, scars, lymph malformations, and obviously if they've been exposed to chickenpox, when they're re-exposed potentially as a toddler, they're at risk of shingles, which is obviously very, very painful, especially for a small child. So the management, if they've never had an infection and they've never been exposed, and you're within 10 days of the contact, you offer them varicella zoster immunoglobulin. You would then advise them to avoid other pregnant women. If they are then re-exposed, for example, 7 days later, you can, and they've still not had the infection, you can re-give varicella zoster immunoglobulin within the same pregnancy, that's fine. If they've got signs of infection, you would treat them with an antiviral. And again, tell them to avoid other pregnant women. You would then refer them to a fetal medicine specialist to monitor the baby for signs that they've been exposed. And you would offer them a neonatal ophthalmic examination. If it's very late on in pregnancy when the mum gets exposed or gets an infection, you can offer varicella zoster to the baby itself if they are within 7 days either side of birth. So if the mum's given birth 6 days ago and gets symptoms, you can give varicella zoster to the immunoglobulin to the baby. If it's 7 days before labour and the mum gets symptoms, again, you can offer the baby immunoglobulins. You can't vaccinate during pregnancy, but you can vaccinate after. It's absolutely fine to have it when you're breastfeeding, and you would recommend they do that before their next pregnancy. Any questions on that? Looks like no, so I'm going to move on. But feel free to stop me if people need to. So the next question is, sorry, actually, so 2 questions. Why no vaccinations because of saliva? Yes, it's because of saliva. If you don't give that vaccination during pregnancy, it's contraindication. And would you still varicella zoster if symptomatic? No. So you only give varicella zoster if they haven't got any signs of infection and they've never had an infection before. If they have an infection, you need to treat it with acyclovir. Hopefully that clears that up. Okay, sorry, question 6. So you've got a 42-year-old woman who's come in, she's 10 weeks pregnant. Her only medical history is type 1 diabetes. She has been told, or she's read on Google, that she's at high risk of preeclampsia. And previously, when she's discussed pregnancy with her GP, she's been told a number of things about her diabetes, including that she might need some low-dose aspirin throughout her pregnancy. She's worried that she's 10 weeks and she hasn't had any so far. Which of the following risk factors is an indication for her for low-dose aspirin? So if we can do the poll, and then Ash will just release it when it's ready. Okay, so there's a pretty even split here between A and E. Okay, so I understand why people have said E. The answer is A, it's the pre-existing diabetes. So the question is a bit of a tricky one, but the question was which of the risk factors independently, so which one on its own is enough of an indication. So when we treat preeclampsia prophylactically, we consider high and moderate risk factors. If you have one high risk factor, you'll be offered 12 weeks, you'll be offered aspirin from 12 weeks. If you have 2 moderate risk factors, you'll be offered aspirin from 12 weeks. So in this lady, her pre-existing maternal disease, which was her type 1 diabetes, is an indication on its own for aspirin from 12 weeks. For anyone, her family history would be an indication in conjunction with the fact that it's also her first pregnancy. or in conjunction with the fact that she's also 42, for example. So you'd have 2 moderate or 1 high. So for this question, it was just type 1 diabetes. Preeclampsia is a very dangerous condition, which presents usually with symptoms of swelling, headache, maybe visual changes. You test them for their blood pressure regularly throughout pregnancy. So often these people have high blood pressure, and you do urinalysis because often they'll have proteinuria, and that's because of damage to the kidney. So what happens in preeclampsia? You don't need to know it in massive detail usually, but effectively when the placenta forms, at a certain stage, the spiral arteries which are throughout the placental bed remodel. If they don't remodel well, they create quite a high resistance in the blood flow through the placenta, which results in a high pressure blood flow and poor flow. So you get high pressure, which is why you get high blood pressure in the mother, which can cause problems to the kidneys. You get poor flow of blood through the fetus. So risks to the mother, it can develop into eclampsia, which is where you start to have seizures. You can get HELLP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. You can be at high risk of a stroke. Again, that's partly because of the high blood pressure and the changes in your clotting risk. We're at risk of pulmonary edema and liver and kidney failure. And for the baby, more likely to be born premature. And again, a lot of that is iatrogenic. So if we know someone has preeclampsia, we're more likely to deliver them early. You can also have reduced placental function, which can mean that you get intrauterine growth restriction, which we'll go through a bit more later. So the management, if there's someone that's at risk, so 2 moderate or 1 high risk factor, you'll give them prophylactic aspirin from 12 weeks. Monitor everyone throughout pregnancy for it. If they have preeclampsia with high blood pressure, you can offer control. First line is labetalol, second line is nifedipine. You can consider IV magnesium sulfate if it's severe and birth planned, and that's partly provides neuroprotection, but also reduces the risk of seizures for the mother, so reduces the risk of eclampsia. The only cure for preeclampsia is delivery. That's the only thing that stops the condition. And you counsel them that they are at risk again in the next pregnancy, but we often deliver these pregnancies early or at term, so at 37 weeks, to reduce the risk of problems with the baby or problems with the mother. Does anyone have any questions on preeclampsia? Nope. Okay. Question number 7 is on gestational diabetes. Again, I'm not going to read it out. So the question was, what's the first line management of this patient's gestational diabetes? So if we can just open up the poll, Ashka. Sorry, this is overrunning, guys. I know we obviously started a bit late as well. If people need to leave, that's absolutely fine. Okay, so there's a bit of a split, but most people have said answer C, which is absolutely right. Most people who didn't say that said metformin, and I understand why people have said that. So we'll run through quickly gestational diabetes. So a few risk factors, pretty much everything: age, family history, past medical history, obesity, multiple pregnancy, also being of an Asian background. Again, we split them into risk to mother, risk to baby. Risks to mother are you're at high risk of a hypertensive disease, something like preeclampsia, at a high risk of traumatic delivery, and that's because the babies tend to be very big, and you're also at risk of stillbirth. Risk to the baby is it being very big. You can get neonatal hypoglycemia, so babies are used to very high sugars throughout pregnancy, and so they might produce a lot of insulin to control themselves. And then they're born and they don't suddenly have these high sugars coming in from their mum, and they have too much insulin and they drop their blood sugar quite low. So you've got to monitor them for about 24 hours after delivery to make sure they don't drop. Diagnosis is with an oral glucose tolerance test. Often it's 24 to 28 weeks. If someone's known to be at high risk, you do it earlier on in pregnancy. You can do it about 12 to 14 weeks. And it's diagnostic if you have a fasting blood glucose of 5.6 or more, or 2 hours 7.8. So just remember it's 5, 6, 7, 8. Management, usually pretty similar to normal diabetes. So start with diet and exercise changes. A lot of people find exercise quite difficult in pregnancy, so she's carrying a lot of extra weight around, but even a half-hour walk each day is good. You then usually your first line is metformin after that. However, if you have a fasting blood glucose on diagnosis of more than 7, suggests your sugars are already very poorly controlled, so you go straight to insulin. So that was the key for this question, was the fact that her fasting blood glucose was more than 7. And then you just monitor BMs. So you tell them they need to be checking their BMs 5 times a day. And then if they control their blood sugars very well, it reduces all the risk of the complications that you just terrified them with of happening. Anyone got any questions on gestational diabetes? When do you give metformin? So metformin is first line if on diagnosis their fasting blood glucose is not more than 7. So if it's between 5.6 and 7, you can start with metformin and diet and exercise changes. If it's more than 7, you go straight to insulin. Any other questions? Nope. Okay, we're going to move on. At the end, we can always leave a bit more time for questions if people still want to stick around and ask any. I'm happy to wait a little bit longer. I just don't want to, I'm conscious we're running over. So the next question is on a 25-year-old lady who's come in with itching. She has a family history of intrahepatic cholestasis of pregnancy, which used to be called obstetric cholestasis. She's got a bile acid concentration of 25 micromoles per litre. This question's on the management of intrahepatic cholestasis of pregnancy. So if we can open up the poll, Ashka. Thank you very much. And then if you just release the poll when everyone's ready. So it's pretty split on this one. Okay, fine. So I'll go through this one a little bit slower. So the options I gave you were chlorphenamine, which is an antihistamine, ursodeoxycholic acid, which helps with the excretion of bile acid salts, vitamin K, which helps with your coagulation cascade, so encourages clotting, topical emollients, which just moisturizers, and steroids, which obviously in general dampen down inflammation. So it's a pretty even split when people answered, but actually the one that doesn't have a role is steroids, and we'll go through why. So intrahepatic cholestasis of pregnancy, risk factors for it, same as pretty much everything. So if you're asked for risk factors in obstetrics, you can usually say personal family history, and then you can usually say multiple pregnancy. That's pretty much safe. Also with this one is the history of liver disease. Risks to baby are stillbirth and baby being born premature. Again, I want to emphasize that a lot of that prematurity is iatrogenic. We know there's a risk of stillbirth that gets worse through pregnancy. So often we deliver these babies early. We definitely wouldn't let them go over term. Diagnosis with symptoms and a bile acid level. You can also look and see if the LFT is deranged. So a bile acid level of over 20 is diagnostic. So between 20 and 40 is mild. Between 40 and 100 is moderate. And that's where you start to see your increased risk of complications. Over 100 is severe. Management, there's actually not much to treat the condition itself. So you start with conservative measures. So you can recommend they wear loose clothing, recommend they take cool baths, use ice packs, give topical emollients to soothe the skin a bit. You can treat them with antihistamines. Now, the antihistamines won't help the itching, but they might help patients to sleep a bit because they make you drowsy. That's the only benefit of those. Ursodeoxycholic acid is the only one that really helps with the symptoms and the excretion of the bile acid. So it soothes the pruritus and helps excrete some of those bile acids. Vitamin K is because if your liver function's a bit deranged, the liver's very important in producing your clotting factors. So you might need a bit of vitamin K to aid in that, just to stop patients bleeding too much. You, as I said, will induce them early usually because you won't want them to go post-term, and you monitor them carefully, especially because of the risk of stillbirth, asking mums to pay attention to fetal movements. And they'll get Doppler and CTG about twice a week, and LFTs and bile acids about once a week. Anyone have any questions on that? So the answer was steroids. So steroids aren't indicated. They won't do anything in intrahepatic cholestasis of pregnancy. Yeah, so fetal movements, mums should be monitoring every hour. Doppler and CTG is twice a week usually, and LFTs and bile acids are about once a week, but it will depend on the severity of the condition as to how frequently they'll monitor. Question of topical cream. I think I said topical emollients. So yeah, topical emollients. So that's just literally just moisturizers. And they just help by soothing the skin. So you can use moisturizers with things like aloe vera in it that just help the skin to feel cool, kind of similar to like after sun. It's just deeply moisturizing. It doesn't actually do anything to help with the intrahepatic cholestasis. As I said, the only one that really helps with that is the ursodeoxycholic acid. Everything else is just a bit of symptom control, might make you feel a bit better. Does that make sense? Anyone got any more questions on it? No, okay, moving on. Question number 9 is about placenta previa. I'm not going to read the whole question, but my question was, which of the aspects of this patient's case puts her at higher risk of placenta previa? So Ashka, if you can open up the poll, thank you very much. Oh, so everyone got this one right. So does anyone want me to go through it or not really? You're all gonna, I think, Ashka, do they all get the slides?
Yeah, they get the slides in the recording.
Okay, so if anyone wants me to go through the slide, speak now. Yes, they do. That's fine, just want to check. So placenta previa is a condition where the placenta is lying low in the placenta, covering the os, so having the spical os. So basically it's covering the exit to the womb. Things that put you at risk of placenta previa are, again, having had a history of it, a multiple pregnancy, as we said before, previous C-section. So having a C-section gives you a scar in the uterus that opens up a place for abnormal implantation. So the implantation often will occur along that scar line where the skin is disrupted, and that can cause problems. Other things, smoking, which this lady had, drug use, and being a bit older. The risk of placenta previa, if you think about the fact that the placenta is overlying the exit to the womb, you're at risk of bleeding both before labour and during labour. Diagnosis with an ultrasound scan, so they'll have a scan early on. Often they'll get told they have a low-lying placenta initially. It might move down, it might move up and away. 90% of placenta previas or low-lying placentas move up and out of the way because as the uterus expands, it just pulls it up. In the So what you usually do, you might find out at 20 weeks you've got a low lying or you've got a placenta previa. Don't worry about it, we'll scan you again at 32 weeks. Look again at 32 weeks, rolls up and out of the way. In the sort of 10% that don't, you scan them again at 36 weeks, and again, about 90% of those have moved up and out of the way. So it's not very common to keep it there. Management, basically you want to avoid anything that's going to disrupt the placenta line of the cervix. So you want to avoid sexual intercourse. You're also going to avoid things like bimanuals if you know that the placenta line there. So it's important to check where the placenta is after 12 weeks if you're going to be doing one. Monitor them if they're symptomatic, so they're coming and they're bleeding. Do as you always do, an A to B approach, transfuse if necessary, consider anti-D if they're rhesus negative, and you would deliver through elective C-section. Obviously, you cannot do a vaginal delivery if the placenta is sitting there in the way. So ERCS, is elective C-section. Yes, it's usually a trans-abdominal ultrasound scan because the placenta isn't formed until 12 weeks. Or isn't fully formed until 12 weeks. Usually the low-lying placenta is detected at about 20 weeks. All the questions. Yeah, anyone else have any other questions? Nope. Okay, we'll move on. Question number 10. Now this is on CTGs. CTGs aren't taught super well. I don't have time to teach them properly, but we'll quickly run through if people are struggling. But if Ash can just put, oh, she's already done it. Thanks, Ashka. So the question was, which of the following parameters would require immediate expedited delivery? Okay, so it's a split between A and E, but most people said A, which is the correct answer. Well done. So we'll quickly run through CTGs. I won't go through much detail. Please do go away and read about them and make sure you're taught about them on your labour ward days. So when you look at CTGs, things you want to look at, the numbers of contractions. So you should be contracting, usually we aim for about 3 or 4 every 10 minutes. Less than 5 is good, more than 5 is a bit too much. You look at the baseline fetal heart rate. Normal is between 110 and 160. If it's between 100 and 110, it's not great, but it's not massively concerning. If it's below 100 or more than 160, that's concerning. You look at variability, so fetal heart rate, same as mine, it's not going to be 60, 60, 60. It might be 62, 58, 64, go up and down a little bit. You expect a variability of between 5 and 25 beats per minute. If it's less than 5 or more than 25, depending on how long it is outside the parameters, depends on if it's sort of an amber risk factor or a red risk factor. Decelerations, so the baby's heart rate slows by more than 15 beats per minute for more than 15 seconds is a deceleration. And you expect that to be, classify it as early. So does it come early in the contraction? Is it variable? Does it change? Or is it late in the contraction? So you look at all those things, you classify them depending on how they are in the parameters as white, amber, and red. And if you want to look it up, RCOG has a really good guidance on interpreting CTGs. It takes you through what each of those 4 things we just described. It takes you through white, amber, and red classifications for each one. And you use that to classify the overall CTG as normal, suspicious, or pathological. So normal, there's only white features, nothing's concerning. Suspicious is you have 1 amber, everything else is white. Pathological, 2 amber, or 1 red, but everything else is white. Usually, if it's normal, just keep monitoring it. If it's suspicious and there's no other risk factors, keep monitoring. If there's other risk factors, you look for an obstetrician to come and you consider expediting delivery. If it's pathological, exclude acute event, things like cord prolapses, implement conservative measures, so you might move the mum around a little bit. If it's still pathological, you might expedite. However, if there's an acute bradycardia or a prolonged deceleration of 3 minutes or more, you need an urgent review. And if there's a bradycardia lasting 9 minutes, or there's evidence of fetal, or you've got evidence of fetal compromise, you need to expedite delivery immediately. So that's why the answer to this one was bradycardia more than 9 minutes. Combinations of the other one might cause you to think about it, but the bradycardia more than 9 minutes is the one that's a real red flag. Someone's asked, does the heart rate change throughout stages of labour? So your heart rate variability will change. So you might have less variability if baby is asleep, for example, and the fetal heart rate might be increased in a preterm baby because their heart rates are slightly faster. It might be decreased if the baby is post-dates, so if they're a post-term baby. And it might be increased if there's evidence that the baby has a bit of hypoxia or a bit of infection, but the stages of labour themselves shouldn't really change the heart rate. You know, if the baby's distressed, baby's distressed. Does that make sense to everyone? It's a bit of a whistle-stop tour of CTGs, and I do encourage you to, if you're interested in CTGs, to read the RCOG guidance because it is very good and easy to understand. Anyone have any questions? Nope, I'm going to move on. So the next question is on induction of labour. So we use the Bishop score to calculate the likelihood of induction of labour working. So if Ashley just puts the poll up, thank you, and then just release it as soon as some people have answered it. Okay, so it's a split here between B and D. So people who answered D, you're absolutely right. So the Bishop score is effectively just one of those things you need to learn. So the Bishop score, I don't know why the formatting's gone really weird, sorry about this. As though my laptop broke, so I've been using different computers and I think it's all just been a bit of a mare. Bishop score, the table that we use is on the right hand side. So things you look at are dilation of the cervix, the length of the cervix, the station of the presenting part, so that's usually the head, obviously usually it's a vertex presentation, and it's in relation to the ischial spines. So is it 3 above, 2 above, or 1? The consistency of the cervix itself, is it firm, is it soft? And position of the cervix, is it posterior, so tucked at the back, is it central, or is it anterior? The higher the score, the more favourable the cervix, the more likely induction is to work. If the score is less than 6, it's unlikely that induction will work. If it's more than 8, it's likely induction will work. And that basically just means body's pretty much ready, it just needs a bit of help. If it's not very high, body's not really ready for labour, induction might not be very effective. A few mechanisms you can do. You can try vaginal prostaglandins. So those are tablets, pessaries and gels. You can try an artificial rupture of membranes. You only do that if the presenting part is low and fixed. And that does slightly increase the risk of cord prolapse. So you need to be a bit careful to warn people of that. You can give IV syntocinon. Usually that's just to augment labour rather than start it. You usually start with the prostaglandins first. But you can cause uterine hyperstimulation, so you can contract too much of that, so it can sometimes be a bit titrating, be a bit of something where you have to titrate the dose. It also increases your risk of uterine rupture, so you need to be a bit careful with it, especially if they've had a VBAC or surgery to the uterus in the past, or something like a myomectomy, fibroid removal. Special cases, things that you can also do, you can offer a membrane sweep if a baby is at term. So that's basically inserting a finger into the cervix and just sweeping around the edge, and that just encourages, the idea is it releases some prostaglandins and encourages the cervix to dilate. The other thing you might do, if you have intrauterine fetal death and you're trying to induce labour in that way, you might use mifepristone and misoprostol instead, similarly to how you manage miscarriage. So do you have any questions on induction? No. Okay, we're gonna move on. Question 12 is about VBACs. So Ashka, if you can pop up the poll. What I'm asking is which is an absolute contraindication to VBAC? As I'm sure you all know, we have relative and absolute contraindications to things. I'm asking which one alone is an absolute contraindication to a VBAC. I don't know why all the answers are, or the options aren't showing up there. Sorry about this. And just whenever you're ready, Ashka. Okay, so again, a bit of a split. Most people have said A, which is absolutely right. So previous classical C-section is an absolute contraindication to a VBAC. So VBAC is vaginal birth after cesarean section. Success rate is actually quite good. It's 70-75%. Goes up much more if it's your second VBAC. Things that make you more likely for it to work is if you don't have to be induced, if you've had one that worked before, if your baby's a normal size, and if your baby's head down. There is a risk of VBAC with uterine rupture because you've got a scar there that's a little bit less strong on the rest of the uterus. It's about 1 in 200. It increases with use of syntocinon, so you ideally don't want to induce or have to augment labours with syntocinon in these patients. Relative contraindications are things like 2 or more previous C-sections, a need for induction of labour, and a previous labour that suggests that a baby might be difficultly sized. Absolute contraindications are anything that contraindicates a normal labour, so things like placenta previa, and a classical cesarean section. The scar is too unstable and you're at high risk of rupture. I don't have any questions on that. Sorry, you can't see the whole slide, but when you get the slides, it will have everything on it. So a classical C-section is one where, so normally you'll have a lower segment C-section. It's what we do nowadays. Classical is higher. And usually that's done because of something like placenta previa or placenta perpetua or accreta, so something in the way at the bottom, which means you can't cut through there. Okay, I'm going to move on because I don't think there's a, oh God. Sorry, everyone. Okay, so the next question is on placenta percreta. So again, just pop up the poll for me, please, Ashka. Almost there, guys. Thank you. And again, sorry, it's cut off the bottom one, but that shouldn't matter for this question anyway. Okay, and just, oh, sorry, okay, so people have, it's a 50-50 split between B and C. So this isn't taught very well. The answer is C. So I've got a little diagram. I couldn't find the reference for it, but I did not make it myself and I don't want to take credit, but it's everywhere on Google, so I don't think it's particularly special. So normal placental implantation is on the endometrial surface. Placenta accreta is where the placenta is invaded through the endometrial surface and is sat on top of the myometrium, which is the muscular surface. In placenta increta, it goes into the myometrium, and placenta percreta, it goes through the myometrium, through the serosa, and can start to invade other organs, like the bladder. So the way I remember it is Increta is in, and percreta, per means through, so percreta is through, and then just accreta. You can also remember it, some people I used to know remembered it in alphabetical order, AIP, on, in, through. The other two options were placenta previa, which is obviously your cervical one, your placenta covering the cervical os, and the other one was vasa previa, which is where, well, as the definition says, the fetal blood vessels run close to the opening of the cervix. So diagnosis of placental implantation orders, you're at increased risk if you've had a previous C-section, as I explained previously, or if you've had uterine surgery. You're at higher risk of antepartum and postpartum hemorrhage. You're at high risk of uterine rupture, and you're at very high risk of hysterectomy, because often, especially things like percreta, where it's invaded through and it's potentially even attached itself to the bladder, the only way to treat it really is to remove the uterus. You diagnose it with either ultrasound or with an MRI, or after a hysterectomy it's diagnosed histologically. You often don't see it antenatally, but ideally you would diagnose it that way. You might see various things. So in ultrasound, you might see disruption of the bladder myometrial interface. You might see some increased vascularity. In MRI, you might see the uterine's a bit bulged. You might see there's some invasion of other pelvic structures. The treatment is, if they're bleeding, you transfuse them, same as you do with everything else. You try and remove the placenta, or you do a hysterectomy. Sometimes, so there's been some studies recently that found actually you have less bleeding if you don't try and remove the placenta at all, but you just go straight to a hysterectomy. Obviously, that has a lot of implications for the woman and future pregnancy and things. So it's really important to consider. I think there's one comment. No, that's fine. Okay, any questions? If not, we're going to go on to the last question. If they're still here, well done. No, okay, we're going to move on. Last question is, again, sorry, I don't know why it's almost like this, but again, it's something that I don't think is taught very well in med school. But what is the most common cause for a fetus being small for gestational age, is the question. Oh, okay. So we've got a split between A, B, and E. Now the answer is A. The most common cause of small gestational age is babies just being constitutionally small. So I don't think this is taught super well, so I'm going to go through it a little bit. What you need to consider here is the difference between small for gestational age and intrauterine growth restriction. Small for gestational age just means that the expected fetal weight, or the estimated fetal weight, or the birth weight, is less than the 10th centile when you put it on the growth chart. 60% of those are just constitutionally small, so they've got nothing wrong with them. Their mums are small, their dads are small, genetically they're a small family, they're completely healthy, they're just on the small side. Intrauterine growth restriction is where baby hasn't reached its growth potential because of external factors. Now, a baby doesn't have to be small for gestational age to be restricted, because it could have genetically very big parents, be smaller than it should be, but not actually be in the bottom 10 decile, in the bottom 10 centile. So, causes of intrauterine growth restriction are fetal, maternal, and placental. So fetal, things like chromosomal abnormalities, infections; maternal, chronic illness, so things like diabetes, things like high blood pressure. Some medications can cause it, and substance misuse the same. Placental factors, so things like preeclampsia, abruption, abnormal implantation. The other thing you can consider is low birth weight and very low birth weight. So low birth weight is if they're less than 2,500 grams, and very low birth rate is less than 1,500 grams. And that's regardless of gestational age. If they're small, they're small. So I just put that in there to clarify, because I don't think SGA and IUG are often differentiated well. So I don't have any questions on that. That is the last question. I feel like the answer is no. I'm going to put up the feedback forms. I think most of you have seen them already.
Yeah, I've
anyone?
put it in the chat as well. For people who are leaving early.
Perfect. If anyone has any questions, I'm happy to stick around and answer them, but hopefully that's fine. Sorry I overran so much, but it's a late start, unfortunately.
Yeah, we started a bit late. Apologies for that. Thanks for coming, everyone. Our next session is on Tuesday next week. Replacing a session which was postponed in, I think it was in April. It's on ortho and room. Well done, Married. That was great.
Thanks. Many technological issues, but we got there in the end.
Yeah.
I'm assuming no one has any questions, so am I all right just to head off?
Yeah, that's fine. I'll end it now.
All right. Thanks.
Thank you for today.
Bye.
Bye.